Hello, and welcome to the presentation entitled Our Forgotten Communities, where we'll discuss the adversities plaguing the health and wellness of our rural communities. Amber waves of grain, countrysides full of trees, flowers, and the only sounds you can hear are those of the wind, birds, and of nature herself. Ah, yes, to live in the countryside, where your closest neighbor may be miles away or just a few hundred feet, but fenced in by nature herself. For many, this is a dream area to live, but has a hidden and potentially nightmarish consequence. As the issue of health insurance and access to health care litter our televisions, newspapers, and daily conversations, access to primary care physicians and emergent care in rural areas is becoming problematic, and people in these areas are finding themselves without such services, as well as increased challenges with the adversities plaguing their communities. Race, education, geographical region, and social economics, as well as the cultural and societal accepted behaviors and practices such as alcohol and drug consumption, poor diet, poor health, that increases the disparities in mortality and morbidity in rural communities, is creating impacts on neighboring communities as well. If federal, state, and local governments would pull funding into the areas and utilize technologies such as telemedicine, telemonitoring, community paramedic programs, and others, the personal and societal wellness could improve in our rural communities. As more of us find ourselves with health insurance under the Affordable Care Act, our rural communities are struggling to attract and or just keep the health care providers they need to maintain the basics of health and wellness. Private and public health care in rural areas lack the population needed to maintain operational funding of such services, and local rural governments lack the financial tax base and infrastructure in order to even consider subsidizing these facilities to even keep the local hospital emergency departments or the hospitals themselves open. In the past 2 years, Georgia has witnessed the closing or partial closing of 8 of its hospitals in its rural communities, and threat of many other hospitals closings hang in the balance. Rural communities make up only 19% of the total U.S. population as opposed to 80% in urban areas. So funding for rural health communities is pragmatic and potentially controversial at best. Without funding of these communities, education, access to basic health care needs, and even hospitals, it becomes easy to understand why rural communities, especially minorities in these areas, suffer more and have higher readmissions to a hospital for such diseases as hypertension, diabetes, depression, and congestive heart failure. The breakdown that occurs in these communities creates an erosion of the dimensions of wellness, as intellectual wellness suffers from poorly funded school systems and other socially accepted disregards for education in these areas. Rural areas have a 23.2% dropout rate as opposed to a 17.6% in the city and 18.4% in the suburbs. With intellectual wellness compromised, occupational wellness suffers, as an already limited business base for potential employment may require the educational standards to perform these duties for employment. With no employment to provide for their family, the financial difficulties increase. Environmental issues result in poor housing and diet. Reduced or absent income, as well as limited access to physicians, will eventually turn a minor illness into a complex chronic condition, resulting in financially devastating and potentially an unmanageable life-threatening condition. While on the surface, it may appear that the impact is solely on that of our rural communities, all communities are impacted by the adversities and disparities facing our rural communities. Patients in rural areas, if capable, will seek out primary care, in many cases only when they feel they cannot hold out any longer, potentially resulting in extended and expensive hospital stays that they, nor possibly any of us, could ever afford. Others may seek out care but utilize neighboring hospital emergency departments to act as their primary care physician, causing increased volume as well as increased wait time at these facilities for those that may require more urgent care. Both circumstances increase the morbidity and mortality of patients that is otherwise preventable, as well as a tremendous burden on our healthcare system. The CDC confirms the overutilization of emergency departments in the South, with an annual average emergency department visit per 100 population is at 47 visits. The report confirms the overutilization of emergency departments for primary care services and that a major improvement in access to primary care could substantially reduce costs and prevent overutilization of hospital emergency departments for those non-emergent care. Nevertheless, the issue is more than that. The inability to move out of an area with limited resources to improve access to health and wellness resources results in generation after generation becoming less able to care for themselves and more reliant on a system that places more money in urban areas. Health and wellness in rural areas, if not addressed, will result in increased disparities as well as increases in the total healthcare expenditures. With the social economically disparities facing rural communities, many living in these areas are unable to leave their lifelong homes for an urban area, nor should they. The burden of health and wellness is inevitably going to shift to that of the surrounding hospitals and the healthcare system as the populations will enter the healthcare system with more advanced medical conditions. Given the poor financial state of many of these communities, they will utilize the local 911 EMS services as a means for transportation to hospitals. This is placing an increased expense on Medicare, Medicaid, and commercial payers for ambulance transports not needed, which increases the total cost of health care. In a study published by Medicare on utilization of medical ambulance transports 2002 through 2011, they determined that Medicare spent $1.98 billion on ambulance transports by patients that did not require the service. Numbers as high as 40% of the patients transported by EMS did not require ambulance transport. National models suggest that if patients were transported to a physician's office, Medicare could save $559.87 million per year, and if they were treated at home, it is expected that the savings could be significantly higher. As these services are pulled potentially miles outside of the communities they serve, others within the area may find themselves without an ambulance to respond to a true emergency, resulting in poor outcomes, compounding the problem. Without getting physicians into the area, the issue will worsen and push more people towards urban areas. The demand will drive the solution. The underserved must be represented and advocated for, and legislators must understand these communities' needs. Albert Einstein once said that the definition of insanity is doing the same thing over and over and expecting different results. Nonetheless, we continue to do just that. One step we can take is that we must work with uninsured patients to seek financial assistance when they enter a rural or urban healthcare system. When patients come to the hospital without medical insurance, hospitals should work harder to assist them in evaluating and completing the necessary paperwork to receive potential healthcare funding. It was found that roughly 80% of the uninsured patients who come into the emergency department are eligible for some type of publicly funded program. This small step alone will assist in financial issues facing many of our rural hospitals. Perhaps even re-examining and potentially changing the scope of service for mid-level providers such as physicians, assistants, and nurse practitioners to allow their scope of practice to expand so that they may offset the current and predicted shortage of physicians. Telemedicine access programs in rural communities. Through the use of technology, advances such as telemedicine, patients can access physicians by simply going to a local fire station, church, or school. Programs such as these could provide a basic level of health care where currently none exist. A great example of one is to push from the local fire departments as EMS is that of the placement of AEDs throughout their communities, and now just about anywhere you go, someone in a public area will find this life-saving device. Providing blood pressure monitors to communities as well as programs to provide glucose monitoring equipment to rural areas suffering from increased diabetic issues so that they can monitor and self-treat before they require emergency assistance. Work with potential medical students looking to become doctors to provide assistance and expenses if they would set up a practice in the rural communities. It is projected that the demand for physicians is growing faster than the supply that we have. and by the year 2025, there is a projected shortfall between 46,000 and 90,000 physicians. Without strong pull from rural communities to attract physicians, the health and wellness of these communities will result in the people asking, what is a rural community? Working on building relationships with current resources in a community that can be used to assist in the care of that community. With such programs as a community paramedics that utilize the local EMS services to perform such basic and health safety monitoring, and perhaps changing the current method that these EMS services currently receive payment, could increase the health and wellness in areas, as well as save the nation's healthcare systems millions of dollars. Currently, EMS services only receive reimbursement if they transport a patient to an emergency department. But, as the graph clearly shows, when we work with our communities, healthcare and wellness will improve. Through activities such as these, we can start to provide care for those that are underserved. We can get back to the days of actual health care and away from what we see today as sick care, and provide a better way of life for our friends, family, and bring back the smiles that can only come from a sound foundation of the dimensions of wellness.
Usually when an ambulance arrives at a home, it's because there's an emergency. But in Griffin, EMS crews are making the rounds. No emergency required.
That's right. It's part of a new program by Spalding Regional Hospital EMS, and it's aimed at keeping people out of the hospital. I met with emergency crews and got a chance to see just how they're helping patients get healthy.
You've had your meds this morning?
Vanessa Clark has suffered from strokes and heart problems, and complications have put her in and out of the hospital on a routine basis.
You can just breathe normal.
But thanks to regular visits by paramedic Tamala Tidwell, Vanessa has stayed out of the hospital for about 3 months.
You would just not believe it, how my health is doing, compared to what it was before.
It's part of a new program by Spalding Regional Hospital EMS that's designed to prevent trips to the emergency room by seeing patients on a regular basis. They call it Mobile Integrated Healthcare.
Traditional EMS work, you call 911 when typically it's too late, and the only thing we can do is to rush you to the hospital. We're heading that off. We're going to you now before you need to call 911.
Patients are selected by the hospital and EMS staff based on how many times they are admitted to the hospital. Tamala Tidwell works with patients and their doctors, making regular visits to check up on patients.
All right, sweetie.
Since the program started in October, several patients have already graduated from the program. Right now, 8 patients are being seen regularly. The results are dramatic.
We have some patients that have been in the hospital on average every 2 weeks. They were being readmitted to the hospital for a couple of days to a week at a time. And we've been able now to manage to get patients to where they're out 150 plus days.
Patients just like Vanessa Clark.
We became pretty close, I think, and she calls me if she has issues.
So I thank her tremendously for what she has done for me and what this program is doing for me, because it has been wonderful.
Well, the program is funded entirely by Spalding Regional Hospital EMS. They say that there are already other EMS units across the state that are looking to start programs just like this one. And Gavir, this is an awesome program because she talked about how much healthier that she feels. But while I was standing there listening to them talk and letting her check her, it was almost like it's her daughter visiting her.
That's
so
right.
it's a family type atmosphere when they're in these homes. The other thing is that it saves the hospital emergency rooms a lot of money and a lot of time to see more serious patients. So it's a great program.
It is. It's a win-win, really, because no matter what it costs in the short term, the gain in the long term is well worth it, probably.
Yeah, the health benefits for these patients that they see, it's about a list of 12. Once they graduate, it cuts the list down and they'll move on to the next patients. But an awesome program, and I think they thought this out very well.